Can somebody throw up the CME slide? Shannon, maybe. There we go. Awesome. All right. Well, if everybody's ready. We're in sort of a minute over, so why don't we go ahead and get started? Because I know you've got to run a little bit early, Sangeeta. So good morning, everyone, and welcome to our weekly CMR conference series. Pleased to be joined by Dr. Shaimaa Fadl and Dr. Sangeeta Shah, two of our MRI readers who are experts in congenital heart disease and are going to show us some nice cases related to that. Just a reminder to everybody that these sessions are CME and MOC accredited, so don't forget to text the code on the screen to the number provided. And today's session is also ASRT accredited, so for any MRI technologists in the audience, they can claim continuing education credit. Again, just make sure to text the code to the number, and if you haven't already, email Shannon as a way to register for this session so that we can give you credit. They're a little bit more strict about who can give credit to, so we just want to make sure everybody can get their continuing education. And with that, I'll turn it over to Dr. Shah. Thanks again for doing this.
Absolutely. Good morning. Are you seeing my presentation slide?
We
Yes.
see what we're supposed to. Yep.
Perfect. All right. Well, good morning, everyone. So happy to be able to share information that Shaimaa, Dr. Fadl, and I love to do and kind of obsess about. So we're going to go through some case examples from simple to complex, and hopefully you'll enjoy the journey. Want to kind of talk about just briefly what is textbook. And so it's really good for the boards and things. So what's the most common? Secundum ASD PFOs are the most common. It's in the area of the fossa ovalis. You have to always think, and hopefully we'll reiterate this through this discussion, is that when you have a hole, you should always look for another hole. And when you have a hole, always look for associated other findings. What imaging do we use for this? We can use transthoracic echo, TEE, MRI, and CT. Of course, we're going to be a little bit heavy on MRI in this lecture, given the fact that MRI, I feel, is a mix between echo and CT. And so it can give you the hemodynamic burden as well as the location. Primum ASD is mostly found in kids, but I will show you examples where we diagnose them in adults. It is in the inferior portion of the atrial septum, close to the AV valves. Often the AV valves in this defect will come off at the same plane, and they have a common plane for the tricuspid and mitral valve. Imaging-wise, we look at transthoracic echo, TEE, MRI. I don't think I've done a lot of CTs for primum ASD defect evaluation, and generally surgical closure is what's preferred in this. Sinus venosum defects, it occurs at the mouth of the vena cava. It can occur at the mouth of the SVC or the IVC, so you have to look at both locations. It is the one that's most commonly associated with anomalous pulmonary veins. And here, MRI, CT, and TE is necessary. And one of the pearls is that you can actually have a transthoracic bubble study performed and it be negative and miss the diagnosis of a sinus venosum ASD because the bubbles preferentially go into the right atrium sometimes the way that it's directed. So one thing to always consider. And Dr. Fadl's going to talk through, but usually we used to think that this is a surgical procedure, that people need a surgery for correction of a sinus venosum ASD, but currently in the literature, there is more percutaneous options for this. Unroofed coronary sinus is generally diagnosed in adulthood. The coronary sinus runs in the AV groove, and sometimes there's holes in it, and you have blue blood going into the left atrium. That's why it's usually diagnosed if it's a full unroofed coronary sinus ASD is diagnosed in childhood because of the hypoxemia. However, in adults, we often see a partial anomalous pulmonary vein, and this is associated with the LSVC. Transthoracic imaging can help with a bubble study. If you do a bubble study in the left arm where the coronary sinus, where the LSVC drains into the coronary sinus, you will get opacification in the left atrium before you get opacification in the right atrium. This still requires surgical repair if it's large, but you can, if it's small, have percutaneous options. So let's go through some cases, starting with a 28-year-old who has dizziness, dyspnea on exertion, kind of doesn't understand why she gets these episodes of tachycardia and shortness of breath intermittently. She does have congenital heart disease, which is not what I am going to show you mostly of, but she has simple congenital heart disease. But what was interesting is that she desatted on a cardiopulmonary stress test by 10%. So I'm going to try to do anatomic first, and then we'll go into just showing the location of everything. So here's the liver, aorta, right atrium, right ventricle, aorta, and PA bifurcation. So I'm going to let this play once more. In this individual, anatomic locations are correct. You have concordance between the right atrium and right ventricle, and concordance between the left atrium and the left ventricle. Go to the next slide. This is going to run through a 4-chamber stack so that you can look at the atrial septum. Once more. So for the most part, the atrial septum looks okay. It looks a little bit hypermobile in this view. Next slide. We often do a short axis stack straight through, oh, I hope this plays, there it goes, through the atrium and the atrial septum. And you can see in this view, you get a sense that there's a PFO. It's going to play once more through. This is a really good view. We do this as a gradient echo with small field of view of the aorta, but you also get the atrial septum here, and you get the hypermobility of the atrial septum. And here, if I were to pause, you get the nice PFO and atrial opening. So what's nice here is you can see you have an anterior rim. You definitely have a posterior rim on this. So for her, on MRI, QPQS was 1.1 to 1. She had no anomalous pulmonary veins, and she had a PFO. So she underwent closure of her PFO with dramatically improved symptoms. And what was interesting is that her PFO was actually very large. With the largest device, she still has a very small shunt, but she does not desaturate. So take home, PFOs can cause desaturations. We always think of strokes and things like that, but in the young individual, desaturation is a possibility. Cardiac MRI images to think through, and this will be the theme, is short axis through the atrium. Consider small field of view of the short axis of the aortic valve, which is a really good picture of the atrial septum. You can also do first pass through the atrial septum with Valsalva with a couple of cc's and see if it puffs over to the left atrium. QPQS is important, and pulmonary vein assessment is important. Case 2 is a 19-year-old who was seen here originally in October 2022.
Sangeeta,
Yeah,
I'm sorry, do you mind if I ask a question real quick?
absolutely, go for it.
So we're asked to do this a lot to try to find PFOs with MRI, and I tend to tell people that we're not so sensitive for that because it only works if you have a case like that where you can recreate some conditions and take crisp images where the PFO remains open so we can see it, right? I mean,
Yeah.
if you suspect highly a PFO, is there anything else you do with image acquisition or breathing techniques to try to keep it open for so that we can image it?
Yeah, I completely agree with you that MRI, this is someone that I knew had a bubble positive study in a sense. So she had a positive bubble study. So I think it's hard. You can Valsalva him on that short axis to see if you can pop it. so that you can see it like that. But generally when they're holding their breath, they're a little bit of Valsalvaing anyway. But I agree with you. This isn't the first modality always to look just for a PFO.
Great, thank you.
Yeah. I think the highlight is sometimes we can see it, and if we pay attention, we'll see it more often, especially in those clinical cases. Thanks, Corey. Yeah, interrupt if you guys have questions. 19-year-old who wasn't feeling well. She thought that she had developed COVID and presented with RSV and respiratory failure. She basically thought she was fine until she was 19, and then COVID had offset her in dyspnea and exertion. She has a medical history of asthma. She had iron deficiency anemia, and she has alpha thalassemia. Play all these. And so again, the 4-chamber stack being important. So in the 4-chamber stack here, you see right ventricle is enlarged. You see a very large secundum ASD, and you see tricuspid regurgitation in this individual. I'm getting there. Taking that same concept of doing a stack through the right atrium as you do a stack through the LV, you can see here's your IVC coming in, and there's a large defect that's here. What's really nice about this is that if you know your slice thickness and you know your width, you can actually gauge the width and the length of the ASD, which is kind of cool. Her slices are generally 8 millimeters thick. Here's that same view, the gradient echo short axis where we're looking at the aortic valve. And you can see here, there's no anterior rim to this ASD. So her volumes by size, if you look, her ventricular volume, 71 cc's, her RV stroke volume was 99 cc's. QBQS was 1.4 to 1, which is interesting. If you did a QPQS, here's her flow through the PA, 85 cc's, and it was 60 cc's through the aorta, again with a QPQS of 1.4 to 1. So you kind of scratch your head and say, well, that looks a lot bigger than a 1.4 to 1. And I'll tell you why in just a second. So going through anatomy here, here's her aorta. Liver is on the right side of the body. I'm looking at pulmonary veins going through. I'm looking at the SVC to make sure there's no anomalous pulmonary veins going into that. An angiogram through it showed normal pulmonary veins as well. So before we even did a T, we knew that there is a large secundum ASD, not amendable to percutaneous intervention because of the size. No anomalous pulmonary veins. QPQS is 1.4 to 1, which we thought was a little bit low. Increased RV volumes with the RVEF that was doing not bad at 45%, and LV volumes were fine with an LVEF of 57. There's TR and MR noted. The reason that her QPQS was off is because she had significant pulmonary hypertension, and this is just showing the cath in completeness. Is you see the PA pressure was 59. And what we did is over time, tried nitric oxide as we treated her with pulmonary hypertension, and her PA pressures did decrease. And her PVR decreased over time. So for her, it was, do we repair her? Do we not repair her? She did have significant pulmonary hypertension. She did have class 2B indication where she did have a gradient of greater than 5, which decreased with pulmonary hypertension medication. So the whole discussion was then based on, let's go ahead and close her, but keep a fenestration. She got closed in April after almost a year of pulmonary hypertension medicines. And this is just to show you her RV function was actually very reasonable after closure. Her tricuspid regurgitation gradient was 36 millimeters of mercury, so her pressures had come down after surgery. And this is just showing the small fenestration, which is actually a large shunt that's left. And that's left just in case the RV cannot compensate for the volume after you close such a big hole. And to say she's doing really well still, which is great. And we'll be going back for a fenestration closure. So take homes, use QPQS in the context of pulmonary artery pressures. So don't stop at that, kind of think about, oh, is this because there's pulmonary hypertension that the QPQS isn't as significant? Always evaluate for anomalous pulmonary veins, and cardiac MRI does allow the visualization of rims. Case 3, 38-year-old Downs patient referred to adult congenital clinic by outside cardiology. He is acute patootie. He has hypothyroidism. He's asymptomatic when he walks up a flight of stairs. He plays softball, and he exercises with a trainer 2 times a week. I don't have a cardiac MRI image of this because we didn't need an MRI to send him to surgery, but I wanted to show you a couple of things. So we're going to look at his case, and this is a primum ASD, and I'm just going to highlight the beautiful ASD here. And the other thing I'm going to highlight is the AV valves coming at that same level. And if you see, some of the tricuspid valve tissue is attached here to the ventricular septum. I'm also going to show you someone who's been repaired and what we need to look at for by cardiac MRI. Here's another picture. Here's a color confusion, but it's gorgeous. Here is your ASD jet, a left to right shunt. Here is regurgitation that's going from the underbelly of the LV side straight into the right atrium. And the reason that I show that is because I want to illustrate that this is one AV valve. So we generally in a congenital heart disease will call this a left-sided AV valve and a right-sided AV valve. They haven't formed into the morphologic mitral valve or tricuspid valve at this point. So I call this case 3B. This is a 46-year-old female who had ostium primum defect, a cleft mitral valve, and an interrupted IVC with dilated azygos repaired at the age of 6. You don't repair the interrupted IVC, just to let you know. So she just had the primum ASD repaired. So what do we need to pay attention by cardiac MRI? I'm going to play this. We've played a couple, so liver's here, and I'm going to play this. What you're going to notice is here's the aorta, but you have this huge dilated vessel here. I'm going to play it once more. So this is someone who has an interrupted IVC with azygos continuation. So your lower body is drained by your azygos and then dumps into your SVC. The aorta and the PA have normal orientation where the PA is anterior and to the left, and the aorta is to the right. This is a 4-chamber stack. And what you start to notice is here's a tricuspid valve and here's the mitral valve. They're in very similar planes. Here she had a primum ASD and you can see the bright suture material. And there's the mitral regurgitation. I'm going to let it circulate once more because I want to show you also the ventricular septum. You see this right here? It's just like the other individual. So it is closed. There's not a VSD there, but it's very thin tissue. She has a huge, that is a left atrial appendage here, and that's what that is. Here's your azygos continuation. Here's a stack of the atrium. You see foreign material here. These are hepatic veins draining directly into the right atrium. Here's your mitral regurgitation. And what you're seeing is that the tricuspid valve and the mitral valve are at the same level. Oops, that didn't work. Sorry, guys. So what I want to point out is here's the mitral, here's the tricuspid, and this is where the cleft was. The cleft was not anteriorly as we see in some adult echo images. It's actually directed more septally, and this is where the suture was placed. So I'll let that play. So if I see someone like this, I know they've had some kind of ASD repair and there's probably a cleft right there. So take homes on this, post-primum ASD surgery, evaluate the atrial septum and the ventricular septum in multiple views. QPQS is still very helpful. Evaluate for mitral regurgitation, which is often present after suture closure. They don't get a ring or anything. And evaluate for tricuspid regurgitation. Look for other anomalous findings during this. In this one, it is an interrupted aortic arch. So I'm going to end there and use the case for next time. Okay, Shaimaa.
Okay. Wonderful case, Sangeeta.
Thank you.
Share my screen. And it's a great pleasure for me to share some cases as well. Starting with the first patient, this is a 45-year-old woman presenting with symptoms of deconditioning and fatigue to an outside facility. These are axial views from steady state free precession images for the heart, and starting superiorly, you can see there is a partial anomalous pulmonary venous return. It's just so much artifact around it, inserting into the SVC. Going a little bit inferiorly, you start to see that there is deficiency of the wall of the SVC posterior wall, and subsequently there is interatrial communication between the left and right atrium. And also here you can see that interatrial communication. Going more inferiorly, there is part of the interatrial communication, but you can see the significant enlargement of the right atrium and right ventricle, enlarged volume, some tricuspid regurg from the dilation of the annulus. This is all because of the left to right shunt. This is a sagittal view through the short axis, sagittal view or short axis view through the atria. And here is the interatrial septum, left atrium, right atrium, and this is the SVC. The SVC is overriding both atria, and subsequently you have some flow from the left to the right side and significant enlargement of the right atrium. The flow images shows that the flow from the SVC is mainly directed toward the right atrium here. And also there's some flow from the left atrium to the right atrium, left to right shunt. This patient also on coronal images, you can see that there is some partial anomalous pulmonary venous return from the right upper lobe inserting to the lower aspect of the SVC. This is a post-contrast T1 vibe, and scrolling through the images, you start to see that there is significant dilation of the pulmonary arteries. This is the partial anomalous pulmonary venous return going to the SVC when you scroll, when I scroll here. And then going more inferiorly, you start to see the interatrial communication here between the left and right atrium, and all the way down, there's significant enlargement of the right atrium and right ventricle. And the QPQS for this patient was 3.4 to 1, indicating a significant shunt. Significant shunt is considered when it is more than 1.5 ratio, but here it's like 3.4. this patient was diagnosed as a superior sinus venosus defect with partial anomalous pulmonary venous return. It's considered superior sinus venosus defect because it's involving the SVC. If it's involving the IVC, it's called inferior sinus venosus defect. And this patient went into surgical repair of the defect and correction of the flows of the abnormal pulmonary venous return directed now to the left atrium. Just a quick hint, it's one of the least types of ESD types, sinus venosus defect. The superior sinus defect is way more common than the inferior defect, and there is significant high association with partial anomalous pulmonary venous return. Like almost 95% of those patients are associated with partial anomalous pulmonary venous return, particularly from the right lung, or only specifically from the right lung. And usually when it is a superior defect, the anomalous venous returns are from the right upper or right middle lobes. And when it is an inferior defect, it's usually from the right lower lobe, but vice versa can happen. And overall, in the pathophysiology, that there is a deficiency of the wall of the SVC, and subsequently there will be some interatrial communication of the both atria. On MR, it's best seen on sagittal or short axis views through the atrial level. And also transverse planes are also very helpful. I find also the flow and phase contrast flow images are really helpful for detecting the shunt. Regarding the management, surgical management was the gold standard, and now there is a really rising role for the transcutaneous management. The whole goal from the management is to redirect to close the defect, redirect the pulmonary venous return to the left atrium, and in the Warden procedure, also the reanastomose the SVC to the right atrial appendage. Regarding the transcutaneous management, covered stents is a good option, inserting it into the lower SVC. And by this, you can close the defect and redirect the flow from the SVC to the right atrium. And this is an example of a patient with a sinus venosus defect and with a covered stent and management. And you can see here a closure of the defect between the left atrium and right atrium, and direction of the SVC contrast flow to the right side. Moving to case 2. This is a patient with a 75-year-old African-American woman. She presented with chronic AFib and remote history of repaired sinus venosus defect at the age of 23, but she is presenting with progressive dyspnea on exertion. And she has got AFib, and there was no surprise that the left atrium is significantly enlarged. The patient had mitral regurg as well, and I have that image for you. What do the MR findings indicate in this image? Is it normal post-surgical repair? Is it recurrent sinus venosus defect? Is it abnormal cavo-atrial connection? What do you think? And the answer is, this is an abnormal cavo-atrial connection. This is the IVC draining into the left atrium instead of the right atrium. And this was inadvertently like a complication post-surgical. Instead of connecting the IVC to the right atrium, the patch was placed and the IVC was connected to the left atrium. So this is like considered right to left shunt with redirection of the venous blood to the oxygenated blood. And these are the sagittal views or short axis views at the level of the atrium, showing the connection of the IVC to the left atrium. And this patient had severely dilation of the left atrium and mitral regurgitation. So iatrogenic cavo-atrial connection can happen, and patients may present, not necessarily present early post-surgical, can present many, many years after surgical repair. So these are coronal images and showing the IVC. These are the hepatic veins and communicating to the IVC, intrahepatic IVC, and this is the IVC going all the way to the left atrium. But the patient has underwent surgical correction. the reconstruction of the atrium, the mitral valve repair, and you can see here that the left atrial size becomes smaller, and the mitral recursion was controlled by the repair, and there was surgical correction of the connection of the IVC directed toward the right atrium. Okay, moving to my last case, 45-year-old female presenting with hypoxia. She was followed by the pulmonology team for a long time for her hypoxia, but recently she was developing worsening dyspnea of exertion, and that's what they requested the MR to evaluate the structure and morphology of the and function of the heart. And I want to share. Do you all see my screen of the case?
Yes, we can see it.
Okay, great. So starting from the superior aspect, let me move that here so I can control. Yes. So these are just the bright blood true FISP images. You can see here that there is a right-sided SVC, left-sided SVC. When you have a left-sided SVC, either both SVCs are equal in size, or the right SVC is smaller or absent even, and the left-sided SVC takes dominance. And scrolling inferiorly, you would expect the left-sided SVC to go and insert its to the coronary sinus, and the right SVC in normal situation should go to the right atrium to have normal connections or normal variation. This left-sided SVC is just a persistent anterior cardinal vein from embryology that did not involute by time. Then going more inferiorly, let me to the short axis stack. It's axial views through the heart, and we can start to, we want to follow where the both SVCs are draining, going more inferiorly. You would, let's track one at a time. This is the left-sided SVC, and you would expect it to go to the coronary sinus, which will be a little bit enlarged in size compared to the prior, like the usual coronary sinus, because of the drainage of the left-sided SVC, which is expected. But going more here, we want to evaluate the drainage of the right-sided SVC, but maybe later we can assess that. These are axial cine images through the atrium. It's the routine short axis stacks that we take, but we start them from the atrial level. And here you can see the coronary sinus, dilated coronary sinus inserting to the right atrium. There is no deficiency of the wall of the coronary sinus to suggest that there is a coronary sinus defect. The function of the ventricles were normal. The sizes were okay, within normal. So the function was normal. Morphology of the ventricles were normal. This is a two-chamber view showing the coronary sinus, which is a little bit larger than size, but there is maintained integrity of the wall separating it from the atrium. So there is no coronary sinus defect, which is reassuring. Moving more to the if we obtained more images to assess the drainage of the right-sided SVC. This is a sagittal view or short axis view through the SVC inserting into the atrium. And at that level, you can start to see that there is overriding cave, superior vena cava over both atria. But this is a little bit narrowed connection to the right atrium, and more that SVC is more directed toward the left atrium. This means that this patient may have some right to left shunt, like which may explain the hypoxia. And now I'm scrolling more images and see phase contrast images to assess that more in details. And here you can see the flow is directed more toward the left atrium when compared to the right atrium. And that connection to the right atrium is a little bit stenotic when compared to the regular superior sinus venosus defect that we saw earlier, but we will compare both cases. So we want to assess by MRA, and these are reconstructed images from the MRA. This is the left-sided SVC draining to the coronary sinus, which is important to recognize because in some patients, you may have left-sided SVC draining to the left atrium, which can result into another shunt. And this is the right-sided SVC, draining mainly again to the left atrium and also to the right atrium, but it's very stenotic communication to the right atrium here. Okay, I'll go back to my slides. So this patient, they referred in the literature as biatrial right-sided SVC drainage, but it's similar to the sinus venosus defect category, but the only difference is that the communication of the SVC to the right atrium is stenotic or atretic, and subsequently the direction of this shunt this time is right to left with hypoxia or desaturation on exercise, but the sinus venosus patients will present mainly with manifestations of left to right shunt and enlargement of the right side of the heart and large right volumes effects. And this is the flow images again. And then I wanted to put side by side the sinus venosus defect patient showing the cable overriding both atria, left and right, and how it is widely communication between the SVC and right atrium, and how the direction of the SVC flow is going to the right atrium. Compare that with what they refer as biatrial drainage of the right-sided SVC, which is the flow is directed mainly to the left atrium compared to the right atrium, and a little bit stenotic appearance of the orifice of the SVC to the right atrium. And subsequently, this is right to left shunt. And this patient was managed by covered stent through the lower SVC. And you can see here that the stent is inserted to redirect on this, direct the contrast or the flow from the SVC to the right atrium. When I stop here, you can see the contrast injection is directed mainly toward the right atrium here, not the left atrium, which is here. So in summary, doesn't want to move forward. In summary, it's important for us as a cardiac imagers to recognize the abnormalities of the cavo-atrial junction, look for them and find them. And if you saw a partial anomalous pulmonary venous return, look for sinus venosus defects. As Sangeeta was mentioning, MRI can be the first modality to diagnose sinus venosus defects. And if there is a negative bubble study, sinus venosus defects, it can be easily missed by echo. It's MRI has a larger field of view, can detect those abnormalities. And thank you very much. And I'm open to questions.
Well, that was great. Thank you both so much for bringing those cases. It really illustrates the concepts well. I think I counted 7 cases that you worked through with us. So Shannon, if you want to indicate that, again, for any of the trainees in the audience, if they want to use some of these for case numbers, just hit the, use the attendance feature. Shaimaa, did you tell us what was the QPQS on that patient, and did her hypoxia go away with the covered stent treatment?
Yes, the patient was doing really well. I remember that the QPQS was not large, was 1.1 or something. It does not, it's less than 1.5, which is expected in those patients because you are directed toward the left atrium and right atrium. So you would expect the QPQS to be low, below 1 if it's right to left shunt, and you would expect it to be higher than 1 if it's left to right shunt. So it was a mix between both. And the patient did really well after the covered stent. Sorry, I want to bring the slide back.
That's great to hear. Thank you.
Hi, good morning. I have a question.
Sure, Leila.
Great cases with Sangeeta and Shaimaa. It's a question for Shaimaa. That biatrial drainage of right-sided superior vena cava, is there a shunt through that between the atria? Or is it just
inter-atrial communication?
Yes.
That's a good question. It's an opening between both. It's stenotic to the right atrium. So you would expect the left atrium has a higher pressure to go to the right side, but you have more volume going from the SVC to the left side, left atrium. So that's a good question. There is inter-atrial communication, but I didn't estimate how much is the inter-atrial communication contributing to the shunt fraction.
Yeah, so what I'm trying to understand is that I might have missed this part. If we do a first pass perfusion and we have the same image as you show, the flow images, what are we going to see? We see contrast coming and going to both atria, right? And
Yes,
then see
mainly,
the contrast going from the left to the right side or something in that line?
It depends which IV you inject in, right?
yes,
Yeah.
correct.
It depends if you're left-sided injection and you give a first pass, it should end up preferentially in the left atrium.
And yes, because so if you have a left-sided SVC, it's draining normally to the right atrium, unless you have a bridging vein. You would go to the right-sided SVC. If you are injecting from the right SVC, it should go to the preferentially to the left atrium, but on the flow images, it showed also it is going to the right atrium as well, going both atrium because it's overriding, but preferentially to the left atrium.
Okay. But that stenotic part is basically preserving more flow going to the right. The problem is more that deoxygenated blood going into the left
Correct.
atrium, right?
Yes, correct. And a little bit, I disagree with that term biatrial right-sided SVC because it's a little bit confusing, but it is how it is described in the literature. It is a little bit confusing with sinus venosus defect. Both are deficiency of the wall of the SVC. It just one has a wide patent opening to the right atrium, and the other have stenotic opening to the right atrium. And
Yeah, exactly. That's how it looked like on
yeah,
images. It's just that the second one was more stenotic. Otherwise, they were the same lesion.
yes. It is. I just mentioned it as it is described that way in the literature. I don't know, Sangeeta, if you have any input on this, but this is how it has been described. But
Mhm.
both is biatrial drainage. It just one is preferential to the right atrium, and one is preferential to the left atrium.
Okay. Yeah, thank you.
Sure.
I think it's a zebra of a case, right? I mean,
Yes.
it's one of those things is, yeah. But she's doing great too. I forgot how many years after, but she does not desaturate either.
That's really nice.
Yeah.
I'm glad that the transcutaneous management works well.
Mhm.
Well, great. Thanks again so much to both of you. If there aren't any further questions, we can go ahead and close the session a little bit early, and we'll see everybody back next week.
Yeah, I'm sorry. I have one question for Sangeeta.
Yeah.
So let's say if a shunt in between the atria is not detected on echo, is there a chance it can be detected on MRI? So basically, do we have a percentage? Like, are there studies to look at incidental finding of interatrial shunts on MRI that were not detected on like a really good in good hands echocardiography?
Yeah, so one is technique, right? Two is shunts are very complex in that echo picks up a lot of them, I would say, with good technique. But a sinus venosum can be missed by transthoracic echo, and someone could have right-sided enlargement. The patient that Dr. Fadl just showed had echoes, is a nurse, didn't show anything. So I feel like that's another incident. And then we see a lot more, and probably because of what we do, anomalous pulmonary veins without a huge ASD. And so we've seen patients with, I didn't show the last case, but two pulmonary veins to the left atrium and two pulmonary veins to the right atrium. We've seen pulmonary veins of the right upper and middle into the SVC without an ASD, but right-sided enlargement. So I think when we see someone and we're suspecting, we're trying to figure out right-sided enlargement and echo doesn't give you the first pass, I think MRI is a very good tool to figure this out.
Okay.
That's a long answer, but does that help?
No, yeah, absolutely. It's basically asking the same question that Corey asked, like, is there a value for
Yeah.
MR? And
I
the answer
just
is yes.
the population.
There are things that cannot be picked up by echo. Thank you.
Thank you, Leva. Have a great morning, everyone.
Thanks again.
Thank you.